Hello and welcome to On Call with the Prairie Doc After Hours. We had many great questions submitted beyond what we could answer during the broadcast portion of the show. Let's get started. I have a grandson who's 17 and he has scoliosis and he needs to have rods put in his back. He refuses because he doesn't want to give up sports. What do you think of that? Ooh, rods in the back for scoliosis.
Complicated question, complicated disease process. At 17, he is probably through his growth spurt.
Right.
That's an important factor as to when you decide to operate on a scoliosis. Statistically, he would be past his growth spurt at that age. The curve usually accelerates during the time of the growth spurt, so it's probably maximized at this point. But when the curve gets to a certain point, it's more likely to progress as the years go by, and that would be an indication for surgical stabilization and or correction.
That's a pretty significant curve though, isn't it?
It'd be in the 40-plus category for most surgeons.
40% grade. So
40 degrees of a curve measured from the top to the bottom of that curve. So it's a clearly visible curve to a non-medical person. They're sometimes well compensated. You can have a curve in the rib cage part of your spine and have a compensatory curve in the lower back part of your spine. So with a shirt on, it's fairly well masked, but when the shirt's off, you can see it usually quite plainly.
Generally when they bend over, you can see the hump.
There'll be a rib prominence because part of the disease process is rotation of the vertebra, which in turn rotates the ribs with it. So it's a tough call. Unless there's an underlying reason. Idiopathic scoliosis is very different from the kinds of scoliosis that are caused by other diagnoses.
Idiopathic meaning we don't know what the heck is it caused.
We don't know what causes it. It's a spontaneous process that we don't know really
Other
why.
causes would be polio or any neurologic.
Neurofibromatosis. There are spinal muscle atrophies that can cause them with different characteristics in their curves. To the grandmother who's asking this question, I would recommend a second opinion would be a worthy consideration. And I don't know who her first opinion is, and I don't care. I'm of the belief that we should all never be too proud to ask for a second opinion. If we all read the same books and follow the same ethical guidelines, we should get the same answer, irrespective of which doctor we go to.
Right.
So if she's concerned or not clear or isn't getting her questions answered, a second opinion is always appropriate. And I commonly tell patients that any doctor that doesn't want a second opinion is probably a doctor you should not see.
Right. If that doctor gets offended and pitches a fit, then you need another doctor.
Pick another doctor.
If he or she said, great, and that will give you reassurance if that answer is what you need.
Full speed ahead.
Please explain a partial knee and what condition is best addressed by this procedure. I have bone on bone on inside the right knee. Might I be a candidate for partial knee?
Might be. And by that, it's surgeon judgment. The partials don't have quite as good a track record as the totals, but if the patient truly has what we call unicompartmental disease, meaning the lateral compartment is, assuming medial compartment, it could be lateral. The other side of the knee is in good health. The articular cartilage is healthy. The meniscal cartilage is healthy. The kneecap articulation is healthy. And it really is truly one component, one compartment. Then it's a worthy consideration in the right hands. But they have to be very carefully aligned. Otherwise, the bending moments can cause it to fail early.
Alignment is the key.
Yes, sir.
I have knee buckling lately and my hand will jerk also. I'm going to have a brain MRI tomorrow. Dr. Holm, any ideas what it could be? Well, I would ask you too, Mark. Knee buckling lately. All of a sudden they're walking along and then a knee goes out and also the hand is jerking. It's almost not enough for me to get the answer there. I sense that there might be knee buckling in one side only would imply that there's weakness on one side. The hand jerking, I don't understand what that is.
I don't.
Any clues? Or my sense though is a neurologic problem is certainly worth looking at, and I go along with the brain MRI.
Right. What she has now are symptoms. We don't have a diagnosis. Another point of emphasis for me with my students is to always emphasize that we need to find a diagnosis. Patients come to us with symptoms. We have physical signs on our examination. We do imaging studies, but we need to come to a diagnosis because without the right diagnosis, we can't render the right treatment. So she has symptoms that at this time have not defined a diagnosis. So is the knee buckling because the quadriceps is weak? Is the knee buckling because she has a meniscal tear? Is the hand jerking because she's having
Partial seizures.
Is it from the cervical spine? Is it from seizures? All of these things are in the realm of the possible. So her physician needs to start to narrow down the diagnostic possibilities, and an MRI is a reasonable place to start if he believes it is neurogenic in origin.
Right. Neurogenic, meaning from the brain or the spine or the nerves. I just wanted to thank you. That was that thank you from Marianne Johnson. I love that. I have a loud crack in my knee, and it just gave out on me. PA says, based on x-ray, they won't do a scope unless I feel more pain. Had a loud crack, and it just gave out on me.
And I agree with the PA that that isn't an indication for surgery. A crepitant joint is pretty common, from knuckles cracking to kneecaps cracking. If it doesn't hurt, it probably doesn't represent a pathologic process, a disease process.
So cracking or crackling or snapping and popping when you bend your knee, I have that, and I ran 8 miles today, and I think that that's pretty common. It doesn't mean anything.
And in shoulders, it's common as well. So unless there's pain associated with it, it's leave it alone.
But it gave out on her. And so the question I have is, giving out is another story. Sometimes people hear a noise and then it frightens them and they move in a different direction. I would be careful about that. Certainly, scoping this is not enough for a scoping.
No. Again, there's no diagnosis. There's no indication in this day and age for exploratory surgery, given the wonderful imaging technology that the physicists have provided us. With their MRIs, we can see into virtually every body part and have a clear diagnosis.
Crepitance is that sound that you feel if you put your hand over the knee and you move the knee back and forth and you go grind, 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 grind.
Yes.
Do you believe that that is always indicative of the severity of the problem or not?
Not. No, because it can be from soft tissue as well. On the outside of the knee is a structure called the iliotibial band, which very commonly rubs across the outside of the knee bone, and it gives that sensation of catching, grinding. It can be soft, it can be hard in different people, but it doesn't mean the kneecap's unhappy. And again, pain is the indication to proceed. Pain is the body's alarm system, and if the alarm's not ringing, then we don't need to chase it far.
But I would say, as an internist, a lot of people have pain, and it doesn't necessarily mean as well that there's something bad going on. Sometimes you explore, of course you should explore, but sometimes you don't find an answer, and it means let's give it a little bit more time. It's sort of like that feeling you have when there's a zit that's kind of dwelling inside there and it wants to come out, and you're not going to want to squeeze it. You don't do anything, you just put heat on it and you go, what is it going to do? Let's see how it manifests itself over time.
Sure.
I had a total knee replacement 2 years ago. I continue to have a burning sensation in the kneecap. It feels like I have a rug burn or something of the sort. Surgeon recommends I wear a hinged knee brace. I have no relief from the pain thoughts. This is a burning sensation in the kneecap.
Okay. When we do the incision for a total knee, right down the middle,
Right.
we almost always cut the saphenous nerve as it crosses the midline. That can sometimes develop a neuroma. And that neuroma can create this kind of burning pain right in the front of the kneecap that this gentleman or this patient is describing.
A hinged kneecap, hinged knee brace, what do you do for a neuroma?
I'd inject it first. I would check a Tinel sign to see if I can isolate the spot where that nerve is most tender. And then I would inject it liberally with
A steroid
with Marcaine and a steroid. And I had a gentleman in the VA hospital in Milwaukee when I was staffing cases there a couple of years ago who came in with this identical symptom. And in the clinic, we injected his knee. He came back in 10 minutes later and said, I can't believe it, my pain is gone. I hope this is that simple. I hope this resolution is that simple. I'd try that first. If the pain doesn't go away with that, then I would be concerned about patellar alignment. Is the patellar implant sitting right in the center of the thigh bone component, what we call the trochlear groove? Because patellar misalignment is one of the leading causes of total joint replacement
problem.
unhappiness.
Yeah. Surgeon recommends a hinged knee brace. That's not been your go-to
Wouldn't
plan.
be my choice, no disrespect intended, but the hinges are usually to stabilize the joint. Unless this person has other instability issues, I can't see where that would be a benefit.
What about rotator cuff replacement? What do you think about shoulder, rotator cuff
Repair?
and replacement? This guy said replacement.
Well, we generally
Total shoulders.
total shoulder replacements are a good pain relieving option. Rotator cuff repairs are common. They're successful if the tear is relatively fresh and not retracted and not chronic. The greater the chronicity, the longer that tear has been there, the more the tendon has retracted, the more the muscle has been replaced with fibrous tissue and is non-contractile, the less likely you're going to have a successful repair. So early on, it's like fixing an Achilles tendon or any other tendon. They generally do well, but if they're chronic and severe, then they become what we call irreparable rotator cuff tears. And we generally don't operate on them until they've done extensive therapy, had extensive conservative options, and until they get to a certain, I don't want to say age, because it isn't as age dependent as it is activity dependent, but we will then try a reverse total shoulder, which is where the cup goes on to the humerus and the ball goes into the scapula, which is the usual inverse of what we do. And there have been good reports for pain relief. You don't ever get great function back. But
if you don't fix it before the muscle is atrophied, I mean, the muscle's just been separated from the function that it was doing.
Right.
And it's not, unless you fix that, the muscle goes away.
It does.
And then you can't get it to come back.
It doesn't come back well. Nope, never as good as the original equipment.
My heel bone on my left ankle is split from an old basketball injury in 1971. Heel bone, left ankle, split. My doctor wants to put it back in place by grafting bone out of my shin into my heel bone. I was wondering if that surgery will have any effect on my Achilles tendon. Heel bone, ankle, split, graft bone, Achilles tendon.
I don't think it'll affect the Achilles. I think that if they can still point toes down and point toes up, if the operation is just to rebuild the calcaneus to give that person a better platform to stand on, then it shouldn't affect the attachment of the Achilles.
Right.
If there's a fusion planned as well, which would probably be the more common operation, to fuse the talus and the calcaneus together, then you will get decreased range of motion for both dorsiflexion and plantar flexion, but the Achilles is still an essential component of your stability and your gait cycle.
Okay. I think that does our questions, after hours questions. Thank you very much, Mark, for your help. This has been great. Thank you for joining us on our website. We appreciate all your questions and the opportunity to answer them. Until next time, from all of us at On Call with the Prairie Doc, stay healthy out there, people.